Actually, we do have meetings every week, webinars, lectures as a part of our webinar series. Last almost 1.5 years.
Yeah.
So, topics related to newborn care more of. So this is more interesting actually, and more of academic, and actually I am eager to listen, but I know today
and people will join. They're joining.
Slowly. And Saturday usually what happens, like so many activities are going on simultaneously.
I know it's very difficult to keep up actually. In fact, to cope with them has become difficult.
Yes, sir. So we'll start in 2 minutes, sir. Just a minute.
Sure. Yeah, no problem. So Dr. Sunil, where are you located?
I'm in Aurangabad, sir.
Right. I think we have met earlier.
He's at MGM College, sir.
That's right. Yeah, probably we have met at one of these IAP meetings, I think.
Okay, yes, sir. Possible. Yes, sir. Yeah. And MGM, and I have my private unit also.
Okay.
Yes, sir.
Lots of people come from Aurangabad for opinion actually.
Yes, sir. तर तुमच्यासाठी औरंगाबाद काय सगळीकडे येतात. म्हणजे उलट आम्हाला तर कधी कधी बऱ्याच लोकांना असं वाटत असेल की सरांकडे पाठवावं की नाही पाठवावं, कारण की काय होतं की खूपच म्हणजे सो कॉल्ड सिनियर्स किंवा एक्सपर्ट्सला पाठवताना आपणही विचार करतो यार आपण काहीतरी छोट्या मोठ्या गोष्टी मिस नको व्हायला, सरांकडे जाऊन काहीतरी ब्लंडर नको व्हायला.
नाही, not at all. In fact, anytime in doubt, just to confirm. Because in routine practice, we all end up making lots of mistakes.
आणि सर आता आम्ही पण म्हणजे माहित नाही, संदीप सरांनी ऑब्झर्व केलं की हळूहळू ना काय होत चाललंय की न्यूनेटॉलॉजी मध्ये न्यूबॉर्न मध्ये सुद्धा आता मी जेव्हा रेसिडेन्सी होती किंवा प्रॅक्टिसचे पहिले 2-3 वर्ष इव्हन थायरॉइड ट्रीट करताना सुद्धा आम्ही इझिली त्याचे न्यूक्शन कॉर्नर, छोट्या मोठ्या गोष्टी, इंट्रिकसीज बऱ्याचशा आम्ही म्हणजे आपण खूपच असायचो. आता हळूहळू काय होतं, वामन सर आहेत, सरांकडे पाठवून देऊया किंवा असं होतं बऱ्याच वेळा. आपण हळूहळू प्रॅक्टिस मध्ये ना स्पेशलायझेशनचा जास्त युज करायला लागतो.
ट्रू. खरंय. ट्युब्युलर होते विजन.
होतं सर. संदीप सर स्टार्ट करूया का? Okay. Sir.
Yeah. So, good evening, everyone. On behalf of the Maharashtra State NNF, we welcome you all for today's webinar. It is indeed an honor and a pleasure to have with us Dr. Vaman Khadilkar, sir, who needs no introduction because he is well known in the field of pediatric endocrinology. But I take this opportunity to welcome you, sir.
Thank you.
Dr. Khadilkar, sir, as we all know, is a pediatric endocrinologist. But actually, you will be surprised that after passing his MD, and he had some brief time in Bombay, but he did his graduation and post-graduation from Miras. And then after going to Bombay, he went to UK and he did fellowship in neonatology for 3 years. And then he changed on to become a pediatric endocrinologist, probably one of the wisest decisions. Right. Because we all know how we on a personal level, sir has been a guide and mentor to both Archana and me since we were doing our MD pediatrics. So he has been a constant source of inspiration to all of us. A great, excellent teacher, excellent orator, best clinician, and he started pediatric endocrinology in the state of Maharashtra at a huge scale, and it became recognized as a subspecialty and a super specialty. He has been in the field of pediatric endocrinology, and we have seen how things have evolved. And sir has taken great efforts in the field of growth and development in terms of whether it's the chart, IAP charts, which actually sir has designed in the field of growth and development. Also, we have seen his personal excellence in the field of clinical pediatric endocrinology. He has groomed so many youngsters, and he is a force of inspiration for youngsters to take up pediatric endocrinology, and started his pediatric endocrinology fellowship. Sir has been president of the Indian Association of Pediatric Endocrinology. He is a guide for PhD students, and above all, an excellent human being who is always willing to help one and all. He's like a magnet. When people come in contact with him, people get attracted, and he's a constant source of inspiration to all of us here, not only in Pune, not only in Maharashtra, but recognized faculty all over India. So we welcome you, sir, for today's webinar, and really grateful to you for accepting this invitation at such a short notice. So over to you, sir.
Thank you very much, Sandeep, for that really kind introduction. Not sure whether I'm worthy of that or not.
Sir,
but
it came from here, sir.
But first of all,
any papers.
Thank you. But first of all, would like to thank you and Maharashtra chapter of NNF for taking up this very important topic. It's unusual for a neonatologist to listen to what happens to an SGA baby later on. But I thought it's very important because I'll start my talk. I'll just share my slides, but I do, before I go on to slide, want to tell you one story from this morning. So let me just share my slides. Just a second. So hope you can see my slides now.
Yes, sir.
Okay, so I want to start with this very important story of this morning also. I saw two girls this morning who came down to see me from Mumbai. And this is a very well-educated family who have adopted these twin girls. These twins were born at a birth weight of 1.7 kilos each at a gestational age of 34 weeks. So they were SGAs and they were preterm SGAs. Now they have been under the care of a very able neonatologist and pediatricians who really did so well as far as their neonatal time period was concerned, and subsequently also they're well vaccinated. But at 9 years and 1 month, the first girl menstruated, and at 9 years, 2 months, the second girl menstruated. Their height is 131 and 132 centimeters each. And sadly, I had to tell both these girls' parents today that the final height of your child is going to be 136 centimeters, which is 4 foot 6 inches, and nobody in the world can help you now. So that is the saga of an SGA that I probably end up seeing about 3 to 4 times in a month. And since I have done some neonatology, I know how intense it is in neonatology just to make the little fragile baby survive. And the entire attention is focused towards the immediate care and the subsequent short-term complications. But parents have such enormous faith in you as neonatologists that you actually will not be doing justice to your patient's faith if this is what happens in the end. This is failure of the medical system. This is failure of us as doctors to allow these poor kids to grow to their maximum potential. But for you to understand why this happens, I've got a few slides now. So I'll move on with my first slide. Is that an SGA baby, as you all know as neonatologists, is a Pandora's box. So as the mom opens it, we all get all these horrible nightmares when you have a preterm SGA that's born with a myriad of disorders that's going to come to you as neonatologist. I am going to focus on only certain aspects because you all are much more worse than I am in SGA. But I thought I would put forth you some basic definitions as to intrauterine growth retardation, as used to be called as, is now called as intrauterine growth restriction. SGA is small for gestational age, and IUGR, which is intrauterine growth restriction, refers to a low growth velocity. So you ought to have two separate readings at two different point times, and you should be able to demonstrate that there has been a low growth velocity in the uterus. Then you can call it intrauterine growth restriction or IUGR. As against, SGA is small for gestational age. It's like a photograph, whereas your IUGR is a video. So a snapshot at birth. So you can then imagine that not all SGA babies have IUGR and not all IUGR babies have SGA. The same thing has been depicted in this cartoon here. So what you see here is the bold unbroken line, is that here is a baby who is small for gestational age at birth as a snapshot, but was also intrauterine growth restricted with dropping growth velocity. So this is SGA and IUGR together. The top dotted line is a baby who was intrauterine growth restricted in the last few weeks of gestation, but is not an SGA. And the third one, the dotted line, the bold dotted line, is a baby who was an SGA at birth, but if you see the growth velocity was normal, so was not IUGR. So what is important to understand that you can have only SGA, only IUGR, or combination, and not all IUGRs are SGAs and not all SGAs are IUGR. If you look at the literature in neonatology, there are about 3 to 5 definitions of what is an SGA baby. Some say below 2 standard deviation for weight or length, or for both. Some would say less than 3rd percentile. Some would say less than 10 percentile. It really doesn't matter. When it drops below 10 percentile, it's definitely SGA. So you can have these 3 varieties: SGA for weight, SGA for length, SGA for both weight and length. Now, what happens to these babies when they come out of your NICU and are NICU graduates? I'm not discussing the problems of NICU, such as hypoglycemia, hypothermia, NEC, etc. You all are absolute masters in that. What I'm going to discuss today is mainly these areas of SGA, which are consequences of SGA. So they have growth and other endocrine issues. They have reproductive issues as they become adults. They have neuropsychiatric issues, which I'm not going to discuss because they fall in the purview of developmental pediatrics. And the fourth area, which I'll touch upon, is what happens to them in terms of their risk for coronary heart disease, stroke, and other disorders. My main focus for today's discussion will be on growth and growth-related issues. Now, what happens to all those babies who are born SGAs? How many of them actually catch up? A sizable proportion. In the Western world, nearly 70 to 80% babies will catch up. And as you see in this diagram, on your x-axis is the degree of length retardation at birth. So minus 3.5 Z-score is the most severely retarded, and minus 1.8 is the least retarded. And on your y-axis is the percentage of catch-up. And as you can see, more severe is the length retardation at birth, worse is the proportion of catch-up. So if you are less retarded in length at birth, you are likely to catch up, in simple words. Now, if you look at all the adults who were short and were born SGAs, it's quite remarkable to see the difference in the final height. This is European data, so you will have to scale it down. But on an average, a European man or a woman is shorter by 22 centimeters, which is 10 inches, if you're born SGA to the same pair of parents, Such can be the profound influence of SGA on final adult height. So I have mentioned a few of these things. And one important point was that more symmetrical is the growth retardation, less is the chance of catch-up. So if you're short, if you're light at birth, and also if your head circumference is small, it is quite unlikely that you will catch up. So if the retardation is symmetrical, there's less chance of catch-up growth. Now, you all have been counseling parents and have been actually facing this problem every single day in your follow-up clinics, that many short SGA babies have severe feeding problems and very poor appetite. But please remember that regulation of appetite plays a very important and critical role in terms of catch-up of these babies. Especially in Russell-Silver syndrome and most severe form of SGAs, you may have to put a feeding tube down for quite some time or put a gastric peg and feed through that. But why is it? Why is it that these babies don't catch up? Now, as I mentioned earlier, that SGA is a mixed bag of worms. There are a variety of contributing factors. If you look at the growth hormone IGF-1 axis, it's observed that these babies do have some degree of IGF growth hormone related problems. Many of them are not growth hormone deficient. Most SGA babies are growth hormone sufficient. 95 to 99% are growth hormone sufficient. But their ability to produce IGF at the growth plate level as well as at the hepatic level is limited. And for those who do produce enough, they have a resistance to IGF at growth plate level. So the entire axis is set at a very different level. There is no evidence of major alteration in the hypothalamo-thyroid axis. There was a time when it was thought that these SGAs, especially the preterm ones, may benefit by giving a small dose of thyroxine. But it has been studied over and over again, and it is found out that SGA without catch-up growth have higher fasting cortisol, free T4 and TSH levels. So certainly not deficient, but they have a higher set adrenal axis. And prenatal cortisol may impose early restriction on growth. However, no lasting effects on the postnatal hypothalamo-pituitary adrenal axis have been documented. Now, quickly, I'll take you through the fetal origin hypothesis as it was initially put forth by Professor David Barker. Now, this great man who can see here in the right corner of your screen is late Professor David Barker, who made this very elegant observation from his first paper published in Lancet in 1989, where Barker wrote that if you are born small, you are likely to die of three major killers: type 2 diabetes, heart attack, and stroke. And there are many papers. There are hundreds of thousands of papers published on this in the world literature subsequently. This hypothesis was later coined as fetal origin of adult health and disease rather than fetal origin of adult disease. So what is the hypothesis? The hypothesis is that for whatever reason, when the baby is small inside the uterus, it could be maternal undernutrition leading to fetal undernutrition, fetal factors, maternal factors that lead to fetal growth restriction, because of which you have many organs which are small, such as liver and kidneys. There's also a degree of organ malfunction. There is decreased beta cell mass. You're programmed to be insulin resistant, and you have abnormal vascular development. Then what happens is that when you become overweight, now please remember this is a double hit theory. You have to be born small, and then the trajectory at which you are growing changes. So then you become obese. That leads to hyperlipidemia, type 2 diabetes, hypertension, eventually leading to metabolic syndrome. So if you're born small, you're better off remaining small. But if you're born small and become obese, then you certainly will have a much worse prognosis. Or in other words, what was adaptation becomes disadaptation. So adaptation to the intrauterine malnutrition now becomes a disadaptation in the postnatal life. Now, what happens to long-term outcomes? There is insulin resistance, there is obesity, there is vascular dysfunction, and this Venn diagram here shows that when all three come together, it's metabolic syndrome. So I have said this, so I'll skip this slide. Then they also have reproductive issues. As they grow older, there are major issues related to early puberty, like the case that I just mentioned at the beginning of my talk. That they will always enter puberty much earlier than expected. They do have premature adrenarche because their adrenal axis is set at a higher level. And as they grow older, girls will develop PCOS-like syndrome, and boys do have some fertility issues. So what happens to puberty in SGAs? They enter puberty early. Their puberty is much faster. What I mean is, in a normal girl, the time difference between thelarche, which is breast development, and menarche, which is periods, is 2.5 years. In SGA babies, it is 1 to 1.5 years. So very short puberty time. So they start early, they finish very early. That leads to very short adult stature. They are also prone for premature adrenarche and PCOS-like syndrome. And in boys, they're more prone for cryptorchidism, hypospadias, testicular cancer, small ovarian volume, and infertility. Now, if you look at the age of menarche in various studies, they always have a menarche at an earlier age in SGA across the world, and certainly in India. So on your left-hand side in this graph are children who are normal. And on your right side are children who actually, sorry, the other way around. On the right side, the black diagram is children who are normal. And you have these SGA babies who have precocious puberty, very rapid changes of puberty, ultimate short stature. Now, when you're born SGA and you gain rapid weight, you have lots of visceral fat, which is the central body fat, and increase in the level of IGF-1. That leads to insulin resistance and hyperinsulinism, which eventually leads to excessive androgen production and PCOS-like syndrome, polycystic ovary syndrome. What are the other changes that happen in SGA babies? So they have reduced rate of ovulation, and in boys, the sperm count is less, so they are partially fertile or can even be infertile. Testicular cancers, cryptorchidism, and hypospadias occurs with more frequency in SGA boys. Now, what can you do about it? You actually treat them with growth hormone. Short SGAs who do not catch up by 2 to 4 years are candidates for growth hormone therapy. Now, it sounds peculiar, but I must tell you that growth hormone was licensed to treat SGA who remain short in 2001. And 20 years down the line, I am slightly sorry to say that perhaps less than 50% of our pediatricians and neonatologists are aware that if you give growth hormone at the right age, short stature in SGA can be corrected. So the first Dutch trial on 79 children who were treated with 2 different dosages of growth hormone showed that if you give it for a mean duration of 7.5 years, these children reach within their mid-parental height. And higher was the dose, better was the response. You can see in this cartoon. The top line is the higher dose, 2 milligram per meter square per day. And this is 1 milligram per meter square per day. And you see here, the longer you treat, the higher is the dose. Eventually, they will reach the 0 Z-score, which is the normal height for mid-parental height. Now, these black dots in this diagram are children who were SGAs at the onset of growth hormone therapy. And 6 years later, all of them have actually gone into the normal range. So when you pick them up early, treat them effectively and long enough, they will reach adult height, which is normal. Long-term studies of adult height have very clearly shown that, just focus on the last column, that final adult height is within normal range in most of the studies done across the world. Now, as I said, final height is within mid-parental height, although they are a little shorter than the normal children, but still they achieve a respectable height. Growth hormone is a licensed indication for treatment of short SGAs in the United States as of 2001 and in Europe as of 2003. There are 3 different schedules followed around the world: Europe, America, and Japan. The dosages are very similar. Age of start, however, in America is youngest 2 years, Europe 4 years, Japan 3 years. From my own personal experience in India, I would say wait until 4 years because our children are also undernourished, and having a predominantly vegetarian diet, they do catch up a little later than the rest of the population. So waiting up to 4 years, if the deficit is mild, is okay. If the deficit is very severe, at 2 years, you can start growth hormone therapy. Now, are there any metabolic effects of this? Initial studies did demonstrate reversible increase in insulin resistance, which eventually gets better, which has not been substantiated in the subsequent studies. Importantly, no case of diabetes mellitus has been reported in 6,000 patient years on growth hormone therapy. During the treatment, many systolic blood pressure standard deviation scores and lipid atherogenic indices actually decrease, so it has a positive effect. Significant decrease in the fat mass and improvement in the lean body mass has been shown. So growth hormone not only improves their height, it also improves their metabolic status. As far as the efficacy and safety of growth hormone in SGA children is concerned, it's effective. It normalizes the height. 90% of children obtain a height within the target range. It's safe. There are no associated glucose-related abnormalities. And at the recommended dose, IGF-1 levels can be maintained between 2 to 3 SD, and it's safe. Any Indian data on this? Yes, we have our own paper. We have published in 2012. What happens to Indian SGA when they're treated with growth hormone? And in this study, which we had published, 2 years data show that they show a beautiful response. In the first year, they grow 10 centimeters as compared to 5.8 in the control. And they continue to grow at 8 centimeters thereafter, whereas the control grows at 5.5 centimeters. So it works even in Indian children. That is the growth velocity data, as you can see in the short term. We also published a paper recently that does socioeconomic class have any impact on the catch-up of SGAs? And indeed, it does have. If you come from a poor socioeconomic class, you don't catch up as well as you expect. I mean, you don't need to be a rocket scientist to understand the reason. It's nutrition. However, it is important to note that the difference that the socioeconomic class makes is huge. So it's not only nutrition, but it is other health-related issues as well that seem to matter in the lower socioeconomic class and its effect on catch-up on children with SGAs. Now, I'm going to show you 2 cases that I have been following up for last several years. I would say for last nearly 17, 18 years. Now, the first case shows you how nicely a child can be treated. And the second case tells you how it should not be treated. So let me present both these cases to you before I conclude my talk. So this is the first case. Here is a 2-year-old male who presents with failure to grow. His dad is 165, mom is 152. His target height is 165. His height at 2 years is 74 and weight is 7 kilos. He is active, otherwise developing normally. His birth weight was 1.8 kilo at 36 weeks. So he was a preterm SGA, he was a term SGA. Baseline investigation showed a hemogram, ESR thyroid normal, sugar normal, gas normal, IGF-1 low, and BP3 2.3 microgram per ml, which was normal. That is insulin-like growth factor binding protein 3. We advised him to focus more on nutrition, gave him high protein diet, and his height velocity was watched. At 3 years, he came back with a height of 80 centimeters and weight 8.5 kilos. We did a growth hormone stimulation test on him, which showed a very normal response. Peak greater than 7 is normal, he was 12. So this child, despite having a good value of growth hormone, but very poor catch-up, was advised to take growth hormone. But parents thought he was too weak to take daily injection and therefore did not start growth hormone. Very common scenario in our situation. He came back at 6.5 years. His height was 103, weight was 15 kilos. But his bone age, see, his bone age was already showing a little advancement. Now this tells you that here is a kid who is not going to be tall at all. He's going to be short. His parents at this stage agreed to give him growth hormone, but they did not start it until 10 and a half years of age. Very common scenario in India. Many parents do not start it until 8 to 10 years. And it still works, because I'll show you the case as we move on. At this stage, however, his height was 4 foot, 120, weight was 27. His bone age had advanced further, and his Tanner staging was already showing some pubic hair, some genital growth, but a testicular volume of 8 ml. As I'm sure you know, at 4 ml, the puberty starts. So here is a kid who is 10 and a half, already entered puberty, and bone age advancing. So we started him on growth hormone as well as GnRH, which is gonadotropin releasing hormone analog, to block his puberty, which we stopped at 14 years of age. And simultaneously, we gave him growth hormone at a dose of 50 microgram, which was continued until he was 17. So he received growth hormone therapy for 6.5 years. This is a table that shows you age, height, weight, body mass index, bone age, testicular volume, weight Z-score, height Z-score, BMI. I want you to focus on the height Z-score. All along, this child was way below minus 2.5 Z-score. Here we treated him with leuprolide and growth hormone. And his height Z-score improved progressively. And at the age of 17 years, when we stopped his growth hormone, he was within the normal target range for Indian population, and his target height was minus 1.2 mid-parental height, and he's very close to that. Same thing I would like to show you in the growth chart, because a lot of people understand it better when a growth chart is shown. So you all know these are standard IIP growth charts, and here is his line. He was always short, continued to grow along the same line. 10 and a half, his bone age advanced, he entered puberty. So here we started him with growth hormone and GnRH analog. As you can see, he improved. His height got better and better and better. At 14 years, we stopped his GnRH analog, but growth hormone was continued. And eventually, this child ended up within the mid-parental target height. So this is a case where you have done everything right. Your parents have been good. They have followed your advice. Everything perfect. He was monitored throughout the therapy. And his IGF-1 was always kept between +2 and +3 ST. His HbA1c blood glucose were always normal. And in 17 years of age, however, if you see the growth chart, you will notice this child had become significantly obese. So despite all our efforts, these children tend to have obesity. And if he becomes further obese, he will develop insulin resistance and will have metabolic syndrome. So that is something that they're programmed to do. Growth hormone will protect them for a few years, but once it stops, it has got nothing to do with growth hormone therapy, mind you. It is the way these children are programmed. Even if you don't treat him with growth hormone, he will have become obese. So this is an ideal case. Picked up at the right time, advised for many years, did not take growth hormone until 10 and a half. Even at 10 and a half, works so well that he has reached his mid-parental target height. Now let's take a case how it should not go. And sadly, I must say, either because of the parents' reluctance or many a times because of the doctor's errors. And I insist, because of doctors' ignorance and errors, not insisting on and not focusing on short stature. In fact, I once again really plead and urge you all to please measure children's height at least once in 6 months to a year. I see hundreds of thousands of pediatricians' growth files, and the only record I get is weight. You take weight because you have to calculate dosages. Please, if you want to give some service to this nation's children, please take their height as well. So here is second case, 2-year-old male presents with growth failure, 71 centimeters, 7.5 kilos, 1.3 kg full-term baby, severe form of SGA. Dad 170, mom 157, target height 170. All initial investigation normal, but I want to draw your attention to the fact that unlike in the last child, IGF-1 was 92 nanograms. So it was actually much higher and not lower. So this is a child in whom you expect resistance to IGF-1. We advise to improve nutrition. 4 years, he was 90 centimeters, 10.5 kilos. Growth hormone stimulation test once again normal. He was advised growth hormone therapy, initially said they couldn't afford. Here is this picture. You see the clinodactyly, you see body asymmetry. And this kid was positive for Russell-Silver syndrome. He had a genetic mutation for Russell-Silver syndrome. These children have asymmetry, severe form of SGA. They enter puberty early, they have clinodactyly. They also sweat profoundly. Now, he was advised to give growth hormone. He came back at 7.5 years. Height was 107, weight was 15. Bone age again had started going up. And what I want you to look at is that these are his subsequent heights and weights. I want to draw your attention to the fact that at 7.5 years, this fellow's bone age was advanced. And at 9.5, his testicular volume was 15 ml with a bone age already advanced. You normally get a testicular volume of 15 ml at the age of 14 or 15 years. So not only he started entering puberty early, but he progressed through puberty so fast. This is typical of SGA babies. And then at this stage, they were urged to take growth hormone and GnRH. However, they didn't give it. The child continued to grow rapidly, entered puberty very fast. At 14 years, he had adult genital stage. His bone age was 15.5. And at 17 years, this poor kid ended up with a final height of 152 centimeters, which is minus 2.5 Z-score even for Indian situation. And his mid-parental height was very good. It was minus 0.5. So he was nowhere near his mid-parental height. Same thing depicted here. Very similar growth chart to the last child. Actually started growing up so beautifully. So typically a pediatrician would say here, and I have a question for you. What does this sudden change in growth trajectory at 9 years without any treatment indicate? A lot of people will say, oh, great, he's growing fine now. Don't worry, he will be 5 foot 6 inches. Everything seems right. Now he has picked up. He's a late bloomer. Big mistake. What is happening is this poor kid has entered puberty early. You're busy practice, you may not have time to check his genitals. He rapidly progresses, bone age advances, and he stops growing. He stops growing so very early. What would be the ideal treatment here? GnRH plus GH. How reliable is the height prediction based on bone age in the SGA? I must tell you that their bone ages are advanced and height prediction is not at all reliable, nor is your growth chart. So the minute you see this happening without treatment, that's an alarm bell. Whether it's a boy or a girl, doesn't matter. You should immediately check the child for bone age, check for puberty, and I think advise GnRH and GH here. So sadly, this fellow ended up with a target though his target height was 170, he ended up at 152 centimeters. So he remained 18 centimeters short of his target height, unlike the last child. So the take-home message from my talk is about 20 to 30% of SGA babies do not catch up to their genetic potential. In India, from our study, it has been shown that lower socioeconomic class, 50% don't catch up. Calorie-dense feeding in infancy may be inappropriate. The risk of later obesity and metabolic syndrome is quite high. Short SGA children who fail to catch up by 2 to 4 years are candidates for growth hormone therapy. It is beneficial to start growth hormone at a younger age. It's cost-effective. Growth hormone improves short-term growth as well as final height in these children, and bone age assessment is not reliable in these children. Thank you. For those who want to write to me to get any kind of growth charts or any questions, please drop me a mail at vamankhadilkar@gmail.com. I'll stop sharing my screen now.
Yes, sir. Thank you, sir. As always, very crisp and clear message. And I'm sure we all are so ignorant about the SGAs and their long-term outcomes. We are happy once the baby goes home and the first follow-up, and then we are sort of not too attached about what is happening in their long-term outcome. And I'm sure as days go, we see a lot of precocious puberty in these
Yes.
group of babies. So we need to be aware of halting the process of puberty and looking at their longitudinal height and growth. We also have Dr. Simi Nirani, madam. She is attending your lecture, sir.
Great.
Today.
That's wonderful.
Sunil, any questions?
So there's a question, one question only. Dr. Hemant is asking about, are there any specific growth charts for SGAs?
Right. There aren't any, because if you develop growth charts for SGAs, you are going to curtail their growth there and then. So we want them to grow on normal growth charts.
Right, sir.
And there is one question written to me directly. Will there be any difference in preterm SGA and term SGA? And the answer is yes. Preterm SGAs are more severely affected as compared to term SGAs. So I think preterm SGAs, we have to be even more careful.
Madam, she's there?
Madam, sir, I have one or two questions about these babies.
Yeah.
When we are looking at SGAs and we are trying to discharge them, we are all the time concerned about the postnatal weight loss and sort of, we are trying to achieve their weight as per what the recommendations from various nutritional societies have put forth, and they never end up catching that despite giving adequate proteins and calories, and we then allow them to grow as per their normative growth. So in these group of babies, realistically, what should be the goal that we would see in terms of their post-discharge weight and growth?
Yes. I think since the new intergrowth charts have come in for SGA, not for SGA babies, but for preterm babies, and the new WHO charts have come. I mean, they're not new anymore. They came in 2006, but for a lot of people, they're still new. I would say that we should not certainly aim at the 50th percentile as has been recommended. I would say that if a patient starts for weight particularly below the 3rd percentile and that gets around 10th or 25th percentile, that's a good enough category. In fact, if it starts going beyond that, we have to be careful, because these babies will end up being obese. And as far as the height is concerned, if the mid-parental height is say at 3rd or 10th percentile, then that is the percentile we are aiming at, not beyond that. And if you have tall parents, say with a mid-parental height of 90 percentile, then you are actually aiming at 90 percentile for that particular. So for height, mid-parental height is a great guide. For weight, I think WHO 50th percentile is certainly not the right guide for us. In fact, majority of our babies are somewhere cruising between 3rd and 25th percentile. And if you are born small and SGA, I think you shouldn't really aim above 25th percentile of WHO, especially the rate of catch-up. If there is a 2 percentile jump within 3 months, I would be very wary of that. Very wary of that. There is one question Sandeep directly asked to me. Can I answer that?
Yes, sir. Yes.
At 2 to 4 years, we start growth hormone, but there is no response even after 6 months. What to do next is the question. I think if there is no response, there are 2 possibilities. One is inadequate dose has been used. Second thing is the technique may be wrong. And third possibility is we may have to revisit the diagnosis as the cause of SGA. Sometimes if you have something like Russell silver, the dose required is 65 microgram per kilo. So that's what I would do. And there's one more question asked by Dr. Rema has asked that again. Besides looking at the height, how do we follow up the SGAs to prevent obesity? I think I answered that. And how do we prevent dyslipidemia? That is another question. So now that is where at around the age of 10 years or at the onset of puberty, whichever is earlier, we should check these patients for metabolic syndrome. And what does it constitute? This constitutes checking for fasting sugar, 2 hours PP sugar, HbA1c, lipid profile, and blood pressure. So at 10 years in all SGAs or at the onset of puberty, whichever is earlier, we must.
Is there any role of doing a fasting insulin in these babies at some stage to look for insulin?
It was, yes, Sandeep, a very, very good question. It was recommended until 2017 to do fasting glucose and fasting insulin to look for insulin resistance. But the recent guidelines given out by the obesity, pediatric obesity, is not to check serum insulin, but only go by glucose, especially in countries such as India. So when I see a kid who was SGA, who has become acanthotic, has become obese, and the fasting sugar says 99 or 100, which is borderline, I would rather do an oral glucose tolerance test rather than insulin. Because we are not going to respond to insulin by giving metformin, but we would respond to this dysglycemia for sure.
I think there are no more questions, but your talk was quite enlightening in terms of making us really think and think hard as to what we are doing and what we really should be doing, and the need for follow-up in these high-risk SGA population. Does the cause of SGA also determine the metabolic or other outcomes?
It probably does, Sandeep, but we are none the wiser yet as far as their genetic makeup is concerned as to which ones we should be more carefully monitoring. We don't know that, but what you are thinking is absolutely on the spot. Not everybody gets insulin resistance. It has to have some genetic link, but that's not yet very clear. And one thing I wanted to request actually all neonatologists on this platform is that on your discharge card, if you can make the parents or the pediatrician, you may not be the pediatrician once they actually get out of an ICU, just to put a reminder on the discharge card that say watch for early signs of puberty in girls and boys around the age of 6 to 8. And second thing is also check for excessive weight gain beyond 5 years of age. I think we will do a lot of service if on every discharge card that's a standard recommendation.
I think so. I think we should definitely spread this information to many neonatologists.
Yeah, I mean, I think as NNF, perhaps if you do have any consensus guideline written on any of these 2 points are worth mentioning.
Thank you, sir. Thank you so much. It was,
thank you so much,
as always, wonderful listening to you, and so much knowledge we get every time that we listen to you.
Thank you, Sandeep, and thank you so much. Thank you once again for taking this topic up. I think very important topic, but I think in the rut of that intense neonatal care and the intense pressure under which you guys work, it gets forgotten. I can fully understand that. I have lived that life myself, but I think it's important that we address that.
So already people are appreciating your talk and they're giving
thank you,
their impressions. So we'll get back to you for another maybe so-called elite endocrinology for newborns, where we really want to learn so much on thyroid and CH, because there is so much to learn from you. So maybe sometime in the next few weeks, I'll again ask if you are free. We would be really grateful to have your presentation on the common neonatal endocrine disorders.
Thank you. And for all those who are interested in endocrinology, this year, although COVID's sword is hanging on our head, hopefully in November, we are doing the Indian Society of Pediatric Adolescent Endocrinologists biennial conference in Pune this year. So it's at the moment planned to be a physical meeting where it's a bonanza of all pediatric and neonatal endocrine disorders. It's on 12th, 13th, and 14th of November this year. We will be putting up the banners shortly. We are allowed to perform and allowed to conduct a physical conference. Otherwise, it will go virtual.
Right, sir. Thank you. Thank you very much. Sunil, thank you very much.
Thank you, sir.
Ghanshyam, thank you.
Yeah. Thank you, Dr. Sunil.
Yeah.
Bye-bye. Bye now.